Good morning, everybody, and welcome to the Health and Adult Care Scrutiny panel. We have apologies from David Rigby and Lynn Keedy. Two got T's. Minutes of previous meeting. These have been circulated. Do we approve the minutes of the previous meeting? Agreed? Yes, thank you. Do any councillors have any interests they wish to declare? No? Okay, thank you. All items are to be taken in public, so we agree to admit the public. Right, okay, we're going to now swap items 4 and 5. So we're going to do the review of the work programme first. We looked at this last meeting and decided what, if there was anything that we were happy that had been completed and anything that we'd like to carry forward. Does anybody have anything that they would like to add to this, Peter?
Yes, please, Chair. I just wondered, in the light of the professional press recently, if we might have a written update on how we're faring in terms of immunisation status. In infancy in particular, with a particular concern for measles, and also in the light of the report in the BMJ and other papers last weekend about the effects of HPV, please.
Certainly, yeah, we'll add that to the work programme and get a written update on that for us. And then once we've had the written update, we'll see how we take it from there. Okay. Is there anything else that anybody at this moment in time? So Richard will circulate the work programme, so if there's anything that anybody feels that needs to be on, then please do say. But under this item, we do need to discuss specialist vascular services for adults. This item has been to the West Yorkshire Scrutiny Committee. Specialist vascular services for adults is commissioned by NHS England. It's not commissioned by the local CCGs. And there is a proposal for a reconfiguration of this service in West Yorkshire. So the change refers to the number of arterial centres required to provide, and it's the complex vascular care. I must stress it's the complex care. And in particular, those currently delivered by Calderdale and Huddersfield Foundation Trust and Bradford Teaching Hospitals. The vascular services provided by Leeds are proposed to remain the same. So it will mean that the proposal is that there will be no dedicated vascular beds at Calderdale and Huddersfield Foundation Trust. These are currently located in Huddersfield. Instead, these beds will be located on site at BRI alongside the existing vascular beds. And I think what happens at the moment is that 1 week the acute service is provided in Bradford and another week it's provided in Huddersfield at the moment. It will affect approximately 800 patients per year who have their surgery and related inpatient stays in Huddersfield, which will in future be in Bradford, which represents 7% of the total vascular activity across West Yorkshire. It is proposed by NHS England that they have a consultation on this matter. It is for this committee to decide whether we believe that this is a substantial change or not to service for ourselves. If it stayed in with the reconfiguration, this proposal hadn't gone forward, then it would come under the acute services moving to Calderdale, I would imagine. Okay, but this proposal has come forward, and therefore we need to decide whether it is substantial for ourselves. Comments, please?
Yes, well, a certain proportion of that surgery is performed in emergencies, and my concern is, you know, how far are people going to have to travel to get to Bradford in an emergency to have vascular intervention? And it's very clear to me that with Leeds and with the reconfiguration and Leeds and Bradford being teaching hospitals, this is the start, well, this is the middle actually, of a slide of all the important services out of Kirklees.
Yeah, I would endorse that. One can see an argument for having that critical mass of staff in one place, and it seems highly unsatisfactory that the service alternates between Huddersfield and Bradford on a weekly basis. But why not? Let's have it in Huddersfield.
Yeah, just to echo that, I'd be concerned about the waiting time for that service. So if they're rotating between the two areas, people are going to be waiting a long time for an appointment, particularly if they're not willing to travel.
What they're saying is as well is that there's a codependency that's in Bradford and a service in Bradford, which is what the, yeah.
Well, that is what I'm talking about, is if you've got one specialist service in a place, that leads on to you having another specialist service, and in the end, we'll have a couple of cottage hospitals, one of which we're paying through the nose for.
So are we agreed then that it is a substantial change for Kirklees? Yes? Yes. So what will happen then now is the other West Yorkshire authorities will also consider this matter, and we look to, if other authorities think it's substantial, then it will go to a mandatory joint health scrutiny committee, and that process will be put in place. Okay, so we will record our decision, and we will work with the other West Yorkshire authorities on joint committees. All right, okay. Right then, so moving on to item 4 then, or back to item 4 should we say. We have today representatives of the Care Quality Commission. So we've got representatives from the adult social care side, the primary medical side and the dental side, yes. And we also have Simon, Head of Commissioning Partnerships and Market Development from the Council, Saf, Head of Safeguarding and Quality from the Council, and is it Tony Smith from the CCG as well. So you've come with a presentation. We have obviously plenty of questions for you as well. So Helen, are you going to start? If you can introduce yourselves as well when you're doing your part. Okay, thank you.
Hi, I'm Helen Harris. I'm Inspection Manager for Adult Social Care for the Kirklees area. I have been covering parts of Barnsley as well, and obviously I presented to you this time last year, approximately. So I'm talking about adult social care services. So by that I mean I'm part of the directorate that inspects care homes, residential care homes, nursing homes, supported living, domiciliary care, and that can cover learning disability, mental health and older people's services. So our strategic ambitions in terms of the organisation haven't changed. They remain the same as last year. And critically, we are having to deliver these things, these priorities, in line with some changes to our budget. And in line with that, we are increasingly delivering an intelligence-driven approach to regulation. So that means that we're working more closely with our partners, and our data and information that we receive about inspections becomes critical in terms of how we're scheduling our inspections. Key changes in the organisation have been that we've had a new chief executive. Ian Tranholm started last year in May, and he has come from a police background. And he has expertise around information technology, IT systems, and he's bringing in a whole range of changes that are actually making our inspections more time efficient, so that actually inspectors are now using Surface Pro notebooks to actually record information in, and that is speeding up our inspecting times. We've got a new chief inspector, because Andrew Sutcliffe, who was our chief inspector of adult social care in my directorate, left the organisation in the beginning of, or the end of last year. And we now have somebody in place to start who is coming from Oxfordshire, I believe, from a local authority down there to start, and she should be taking up post around May time, I think. We've got a longer re-inspection time with good and outstanding services, so that's moved from 24 months to now 30 months. So those are the timescales. But because we're monitoring services very closely in terms of the information intelligence we receive, that can be brought forward at any time according to risk. We have a much more targeted approach to requires improvement services, and as you'll see as I talk you through the rest of the presentation, we had a higher proportion of inadequate services, which was already starting to improve, to lessen. When I spoke to you last year, around about 8%, as the slides that I go on to discuss show, and that's now below 2%. But what's happened is, obviously, the inspections that were, the locations that were rated inadequate have now gone to requires improvement. Where we find that we are inspecting the location for a second time and the rating is requires improvement, we then have a particular set of criterion that we apply where we must consider enforcement action to lever improvement. And certainly when there are 3 occasions, as it has been for some locations where they are requires improvement, we will mandate a meeting with the provider, and we will meet in a management meeting separately to discuss what enforcement action is appropriate to take in those circumstances to lever improvement. With much more fluidity with our patch working. So although that I am a manager of a team, in terms of how we flex and respond to making sure that we get out to services that we need to, and also that we inspect services within the date of publication in terms of our timescale. So that means for all requires improvement services, we need to be there in the year. For inadequate services, we need to be there within 6 months of publication. And for good services, as I've described, it's 30 months now. Yes, and outstanding services the same, 30 months. But the new key performance indicators that we have in adult social care means that we are being monitored to make sure that all the services are inspected within that date. And that's different to previously, because we had so much risk in the patch, and certainly in our patch as a north area, because it does include Manchester in my local, in my wider management patch of colleagues. And obviously, as you'll have read from the independent age report as well, that was a high inadequate area, which has really seen significant improvement. But what it means is that we need to be able to demonstrate to providers and to the public that we are meeting our promise by getting into those services, albeit for those without the same level of risk, by the date that we're set in our, that we've mandated. And before we would try to do that, but now we are actually mandated that we do that within our key performance management. We have a shorter report format. I don't know if you'll have seen the newer reports that are coming out, but one of the things that we found very difficult, that we felt that was not accessible for the public, was the way that our reports were too lengthy. And although we try to facilitate our reports for a reading age of 11, that's our kind of the way we review how we write reports. sometimes they are unwieldy to be able to understand for a layperson, and that's something that we worked hard on. And so our new report format is much more succinct and more punchy in terms of bullet points, that covers, you know, the high-level information that people would need to receive. It does mean, it does not mean that we have watered-down feedback or information gathering, because our standards of what we need to be able to inspect are exactly the same. And the feedback that we give to providers is very in-depth. So we're mandated to cover exactly the same areas, but we're reporting on it in a more succinct way. And as I've described, we have a much more intelligence-driven inspection method now, and that's, you know, largely due to the way that we're collecting data and sharing information, and cross-directorate as well, because obviously, as a whole CQC, our colleagues have different, you know, bits of information that they come across that they will share with us, and also we share with them. I'm part of a West Yorkshire Patch cross-directorate meeting that David and partners attend to share information of risk across the West Yorkshire footprint. Yeah. Whoops. So in terms of the context of services, these are the rated services at the moment, and the percentages relate to actually services which have been rated. So there will be a proportion of services there from March that have not currently been rated. There'll be new services. And I should point out that community care, it says 8% outstanding. That's skewed because of the low proportion of services we've got there. And it's actually a double count there, because our DCA that we're very proud of in the patch, which is active social care, which has the outstanding rating, that's counted in there. That's why that figure.
What's DCA?
Oh, sorry. Domiciliary Care Agency, so it's home care. So as you can see, the most challenging area here is for nursing care. And what we're finding is the quality of nursing is a concern. And part of that is to do with the low status of, you know, job attractiveness within the sector. And obviously, you know, it goes without saying that I think it's sadly such a privilege to work, you know, and, you know, carry out care in this setting is low status across the board for everybody, you know, who's involved. And that is really a cultural problem that needs to be addressed. And you can see that residential care has the highest proportion of good services. And obviously you're getting a slightly different, you know, client group, that there is, you know, less complexity, although I have to say that the complexity is growing all the time compared to, you know, what it was, you know, even 5 years ago, because people are living longer, and obviously therefore more people live longer, they have more complex problems, and, you know, with dementia as well. So in terms of what I demonstrated last time was the ratings picture, local and national, and that was from the last presentation. So just as a sort of a way of capturing some of the progress that's been made. So last year we were looking at only 55% of services as being rated good, against the national picture of 79, and also just over 8%, well over 8% is inadequate, against the national picture of 2% inadequate. That was last year. So if we flip to this year, and what you can see is that good has really increased there to 72% from the mid-50s, and it's caught up with the national picture at 80%, and also it's 1.7 inadequate against the national picture of 1.2, which is a considerable improvement again. And I think I'd indicated at the last presentation that actually we felt that the figures, you know, would be improving because we'd recently been out to some services which were not due to be published yet. But I knew that, you know, they were turning themselves around as well. But I think why that's significant is in the older age report, the independent age report, it actually does highlight that Kirklees is at 33% inadequate and requires improvement services. But if you think about, you know, at its worst, we were running at something like 18% inadequacy of services. That's probably about 3 and a bit years ago. So obviously, services don't just jump to good, and certainly we wouldn't, because we need to see sustained improvement for a service to be good when it's been inadequate. So there is a trajectory for requires improvement to get to good. So that's why you'll see, you know, Kirklees represented in that way in these figures from the independent age report. So in terms of the active locations, that was the footprint in 2008. I'm not going to go through too much of the detail, but they do, you know, it does reflect obviously similar improvements. But I think that the facts in these figures demonstrates where we've been actually, so that you aren't going to get the high proportion of good services that you'll find in some of the other areas, because we've had so much, you know, poor service to deal with. And those are the ones in 2019. So in terms of what we've been doing well is partnership working. Certainly myself and my colleagues in my team have been very actively engaged with the provider forum and with the local authority networks, and we presented on a number of occasions. We've done collaborative work with the hospices to support their promotion of end-of-life workbook. That was in October last year, which a lot of care homes have signed up to improve their end-of-life care. And we are seeing those improvements as we're going out, because obviously one of the things we do, we can't say to people, if you sign up to this, you'll get a good rate. But what we can say is, actually, if you sign up to this and you actually demonstrate evidence of how it's making those improvements, and you show us that you are working together as a team and getting support from, you know, other experts, partners, then obviously that's not going to be a negative for you. No matter whatever else is going on, we will represent that narrative in the report. I've delivered a presentation on safeguarding that the local authority ran in terms of our expectations around safeguarding people and how we report on those things and what we expect providers to do. And also I have regular inspector attendance at the early warning intelligence sharing meeting, the CHESP, and that's a continued commitment. And probably the most exciting development is that partnered with the provider forum, Karen Podgson, who is the provider of active social care, who has the outstanding rating for her service. She is leading workshops around outstanding care in conjunction with local authority and CCG partners. So what we are rolling out over this year is a series of what outstanding looks like in each of the domains, and we've got one coming up for effective. We've just done earlier in the year, we did SAFE. I attended that, and it's a way of networking, providers networking with each other, but also actually hearing what good and outstanding care looks like and what are the criterion that we apply and what we want to see from CQC's perspective, because we really hope to see services being aspirational now, and certainly for those requires improvement services, we want to lift them out of there to become good, and for those good services, we want to see a proportion of those now to become outstanding. So that's a commitment from my team to the provider forum for the rest of this year and ongoing. The challenges that we see in the sector is around staffing, and particularly in nursing care settings. And we were having a discussion about this, and my colleague Tony was saying that actually what she's finding is that there's an improvement in terms of the amount of staff who can be deployed. But I think that what we're questioning really is the quality, and certainly one of the issues, well, the issues that we have with our inadequate services at the moment in the patch, or poor services, are related to nursing care. So they are the sticking points, certainly. And the repeated requires improvement services. So those services that have moved from inadequate to requires improvement, but they've just still got more work to do. And obviously for those services, some services we have been out to have never been rated as good. And for somebody who is living and that's their home, you know, when you're talking about, you know, people can spend, you know, really significant amounts of time in these settings, sometimes 15 years or more. And it's unacceptable that since we've rolled out our new approach that, you know, they never see good, what we describe as good rated care. And so we do take a tough stance on the requires improvement services, and you know, I certainly make it a mission of mine. We meet with all in Kirklees when we have a requires improvement service that is requires improvement again. We have a meeting with that provider. The older ageing demographic, as you'll see, is inferred with the information in the independent age report, but also with some other data that shows that we've got increased deprivation index, which is coexisting with a high older age range in areas of Kirklees, which are a particular challenge, obviously, to statutory provision. And for us, although, you know, we've weathered the storm with our inadequate services and the extra work of enforcement that takes from my inspection team, the other challenge that we have is with Regulation 12 responsibilities, which we've been given from the Health and Safety Executive, which means that we now have the power to prosecute providers for unsafe care where it's led to harm, where we can prove that harm has been caused by you know, a lack of action by the provider. And obviously the amount of work that then takes to bring a case. We have had one successful case which we brought, which is out in the public domain because it was 2014, 15? 2015 probably. No, can't be. 2016. Anyway, it was one of the earliest prosecutions that was brought against St Anne's for a gentleman who fell out of a shower chair because the moving and handling and the assessment about the chair was, you know, not what it should have been to protect him. And so you can see how important it is for people that we do carry out, you know, those investigations, preliminary investigations, and then look at examining evidence to bring a case. So that's a challenge for us because obviously it's an important part of our work but needs a lot of diligence. So that's the presentation. I have looked at the independent age report. I'm just wondering if there's things that I haven't said. Okay, yeah.
Okay, good morning everybody. My name is David Ross. I'm the Inspection Manager for Primary Medical Services across the whole of West Yorkshire and Harrogate, and obviously Kirklees falls in that footprint. I think this is the third occasion I've come and presented to you now, so I've tried to keep the format quite succinct and followed a similar sort of pattern as to what was used last year. So obviously if there are questions you would like to talk about in more detail after the slides, that's fine. I'm happy to take questions on any matters that you wish to raise. That's fine. Just reflecting on what Helen's just said there, there's been quite a bit of organisational change within CQC across many of the directorates over the course of the last 12 months. We too also have a new Chief Inspector in place now, Dr Rosie Bennyworth. She joined the Commission at the start of March this year, so Professor Steve Field, who's been with us since the start, left after 5 years of service. So Rosie is still quite new into post and just very much getting to grips with the CQC way of working at the moment. Okay, so I'll just talk briefly to the first slide here, which again, similar to last year, gives you a picture of the ratings of primary medical GP services across Kirklees in comparison to both how they sat last year and also how they sit now compared to the whole of the West Yorkshire and Harrogate footprint. So all of the information you see there has been extracted from our systems over the course of the last 2 weeks, so it's quite current and up to date. And the picture in Kirklees generally is still quite similar to the picture across the whole of West Yorkshire and Harrogate. So within Kirklees we're looking at around 97% of GP practices currently rated good or outstanding, and with some quite small numbers of services rated as requires improvement or inadequate. Of the areas that tend to be rated less than good, it's still the case that most of that tends to fall within the key questions of are services safe and are services well led. There is quite a strong link between those two key questions in terms of our inspection methodology, and they're the areas that we're still picking up that tends to be the areas that are less than good across the patch. There is one outstanding rated service there, which was rated outstanding for 2 of the 5 key questions in terms of are services provided responsive and are they well led. So that led to that service being rated as outstanding overall. Some of the highlights that I picked out from that inspection report in terms of the good practice that we identified was things such as some bespoke patient assessment templates that the clinicians were using to assess their patients. They were taking steps to address some gaps in local service provision. So, for example, they were working with local schools on things such as sexual health and contraception matters. They were also providing an in-house alcohol support service and were running monthly mental health clinics through their GP practice. They had also designed, developed and improved some processes as well just to help to meet patient demand. So I think we're all quite aware that access to primary care can be quite challenging at sometimes, and this particular service had done quite a lot of work to help improve that situation for their patients. Okay, so the next slide just gives you a summary of the inspections that have been carried out over the course of the last 12 months in Kirklees, and again just gives that comparison or benchmark, if you want to call it, as to how that fits compared to the picture across the whole of West Yorkshire and Harrogate, which is my team's footprint. Obviously the numbers are quite lower for the Kirklees area compared to West Yorkshire overall, so obviously a change in one rating can have quite a difference in terms of the percentages that are quoted there for the services. But again, you can see that the vast majority of the services over the last 12 months have been rated either good or outstanding across Kirklees. And likewise, the picture is quite similar across West Yorkshire itself as well. Again, the vast majority of services being rated as good or outstanding in the last 12 months. Okay. Again, Helen just talked about ambition for the next 5 years, and again, we're still within the 5-year footprint for our strategy from 2016 to 2021, so it still remains to provide a more targeted, responsive and collaborative approach to regulation to help ensure that more people do get high quality care. And we're still very aware that the landscape out in primary medical services is a constantly changing environment, really. So, for example, in terms of some of the changes that are coming into place with the GP contract for this coming year, there's an expectation that by the end of June that all GP practices will be signed up to what's being called a primary care network, which is where the starting to collaborate more closely together to provide care at a greater scale. So there's all those sorts of changes and challenges that we have to take into account and build into our model of regulation. Again, this is a slide I presented to you last year, but we've progressed a little bit since in the last 12 months in terms of some changes that have come into place for the methodology. It might be better that I'd give some more detail on this in a more informal session in terms of what the approach is going to be. But the three main changes that have come into effect from the start of this month really are that we've brought a system of what's being called annual regulatory reviews into place for services rated good or outstanding. There is a shift to more of our inspections being focused rather than the comprehensive inspections that we've carried out for the last 4.5 years. And we've also introducing ratings for services which are independent consulting doctor services and online primary care services. So essentially these are services where patients are paying a fee to access the service, and we're starting to rate those services from the 1st of this month. I think that's it from me for this morning. Thank you.
Right, so the mental health,
Would you like me just to
inspector couldn't manage to come.
Would I like to just talk the slides to you briefly and then...
Yeah, just talk briefly to the slides.
Yeah,
okay,
sure.
that's fine.
Okay, so I'll just present these on behalf of my colleague. I think they've provided two brief slides. The first one just talks about the state of care report for 2017-18 in NHS mental health core services. And what essentially that is showing is that they're getting up towards 80% of their core services now are rated as good or outstanding, which is an improved picture compared to 16-17. I'm afraid I don't have much more detail behind that, but the picture they're painting is generally a general improvement in the sector over the last 12 months. And then they've also provided a second slide on South West Yorkshire Partnerships Foundation Trust, which was inspected in May 2018. There's some information provided there around the ratings that were awarded at that time, in terms of 3 of the core services being rated and requires improvement, which resulted in the trust being being awarded a rating of requires improvement overall. There were some issues identified with things such as blanket restrictions and nurse call alarms, and the trust are participating in the Mental Health Safety Improvement Programme with NHS England. Waiting lists likewise continue to be a concern within the community mental health services that we're inspecting. And some positives to report are the development of an older persons crisis team in Kirklees, which has helped to reduce the number of admissions to inpatient wards significantly. And also the Kirklees IAP service have been active in finding innovative ways to offer mental health support across the borough of Kirklees. Okay, but I would say if you do have any more detailed mental health questions on mental health care, it's probably worth us taking those away and sharing them with our colleague, who will be able to provide you with a written response on those.
It's dental services there, Jonathan. I think this was an extra report that was sent through. Yeah, it's already got it, yeah.
You've got the extra ones, have you? Excellent, good stuff. So I'm Jonathan Weeks. I'm the inspector for all of West Yorkshire, which again, as Dave mentioned, obviously covers the Kirklees area. And again, this is our second year here, so again, I'll follow the similar sort of areas that I covered last time, but give more of an update on what we've covered in the last year. Okay. So again, similar to the previous years, we've covered another 10% of the locations within Kirklees, and we still don't rate dental practices, so they're either compliant or not compliant. And 65 active locations at the moment, and in the last 3 years, 20 have been subject to a fully comprehensive inspection, which equates to about 31%, which is what we're looking at from a national average kind of going forward. Again, since we've registered all the locations in 2011, all of them have been subject to an inspection. The 31% that I've mentioned there are the ones that have been subject to an inspection under the new methodology. Newly registered providers, if a different dentist has taken over a practice, will be inspected within 1 year of them registering the service. If there's any totally new locations, then they are subject to a registration site visit and a fit and proper persons registered manager interview. For the new providers who are taking over existing locations, they will be subject to a registered manager interview and a fit and proper person check. Out of the 20 that have been inspected, 3 have been non-compliant. These have all been under Regulation 17, which is the good governance regulation, and have been non-compliant with a well-led key question. Of those 3, 1 has been compliant at follow-up, the second one is due to be re-inspected late this month, and the third is pending publication, which will be followed up within 3 to 6 months of publication. So these equate to about 15% of locations which have been non-compliant, and as of this year the average nationally is approximately 18%. And again, common issues that we've highlighted, again similar to previously, so issues with recruitment, not following a robust recruitment process, so not obtaining DBS checks or what kind of relevant DBS checks, references, or maintaining evidence of up-to-date registration with the General Dental Council or evidence of indemnity for the dentists. Management of risk, so risks such as Legionella, fire, the use of sharp instruments. Poor leadership, so not having effective systems and processes in place to update policies and procedures and ensure systems are followed correctly. And then, as similar to last year, a poor approach towards audits, so the audit process not working effectively and highlighting issues that were identified on the day where they should have, if they could have pretty easily identified them, then addressing them. Then again, a lot of positives which we've seen there, so the clinicians following nationally recognised guidance, so from the National Institute, from the Faculty of General Dental Practice, and infection control processes working well, so patient, they all clean instruments, premises are clean and well maintained. Then again, patients, very positive feedback from patients. We give out comment cards when we go out, and some very, very positive, happy patients with the services which are being provided. Again, patients involved in treatments about decisions, so getting given options if they're having toothache, they can have the tooth taken out, they can have the tooth dressed. Sorry. So they can have root canal or different options there. So again, there's full involvement of patients within their treatment decisions. And again, the patients who are registered, they're telling us they've got good access to care, so they can get treatment in a timely way, they can get emergency treatment in a timely manner. So some very, very positive things going on there. And I'll briefly mention about some other work that we're doing as a dental team, which links into cross-directorate working. So in October, we started what we call a thematic probe, which is where we tagged along to adult social care inspections and looked at oral health care provision in care homes. So we're asking staff about what training they've had, how they look after the residents' teeth, and again speaking to the residents as well, saying what is done, have you got access to toothbrushes, toothpaste and things like that. So we're going to be releasing a report in approximately June time which will highlight our findings on that, and there's been quite a great deal of interest from NHS England and Public Health England around this, and I think hopefully it might be able to implement change going forward with that. So some quite interesting work that we've done there.
Thank you very much. Yeah, we look forward to actually seeing that report. It sounds interesting, actually. Collaboration of what healthcare is provided in a social care setting, residential care setting. Before I open it for questions, your last slide, you said good access to care for registered patients. Do you assess the access for non-registered patients and how that's dealt with?
Unfortunately, we don't. We've got no kind of strong levers to play within that. I mean, we're aware of the issue with access in the local area, and it's more of a commissioning issue. That so we've got no levers to play within access for non-registered patients, unfortunately.
Are we dealing with them subheading by subheading? Right. I mean, if I can go to Helen's first. Helen, thank you for the update. Given that there's a deteriorating standard across care homes nationally, I just wondered what your analysis was within Kirklees as to the principal causes. Given that, I mean, we're not quite doing as badly as our football team or the bottom of the league, but if you take a look at independent age, you know, I mean, the heartening thing, to be cynical, is that Manchester are actually the bottom of the league, which is actually quite unusual. I just wondered whether this is really due to market forces, whether you think it's due to austerity, whether it's due to poor skill mix, or whether we've just got more fragile, more dependent elderly people.
That's a $60 million question, isn't it? I think that all of those things really. However, what I'd say is that obviously the figures are lumping inadequate and requires improvement services together in the independent age report, and so what it doesn't really give an overview of is actually those services that have moved from inadequate to requires improvement in looking at it. I think, and certainly if you consider that in Kirklees we were at 18% inadequate when we first started our new approach to inspection, which is, you know, if you think about being an older person or, you know, a carer of an older person looking for care within, you know, a local authority, Kirklees, where that was the case, then that really does minimise choice, absolutely, and it's, you know, it's not acceptable. It's not acceptable to have any inadequate rated homes, is it? But when you consider how that's then improved, I think it's important to look within that context, because actually, you know, we're now under 2% rated inadequate services, which, you know, and I know it's still unacceptable that we have this sort of you know, collection of requires improvement services, which I say is our next challenge really now, to really lever those improvements to get them to good. However, I think what's important to say as well is that actually you can be rated requires improvement without breaching any of the regulations, actually. So in our new approach, it's different to the old style reports, where actually there was a correlation between the rating and the fundamental standards, so the regulations at that time. Whereas now, actually, because we look at all, there's so many, the reports, well, the reports have been provided in a more succinct fashion, but we still cover all the key lines of inquiry, which are, you know, very in-depth. And it means that that actually you might have met those fundamental standards with the requires improvement, so you haven't breached those standards. But actually, to lift you into good, you have to exceed those standards, so step over it to achieve. So I think that it's important to, you know, have that context there. And whilst actually we want to see people exceeding the regulations, because the regulations are just the fundamental standards. They're not rocket science.
Yeah, that's helpful, thank you, because what the public sees is a report in the paper, and they don't often get the nuance that you've...
But also, I think it is important that we are saying, actually, this isn't good enough, so I don't want to be complacent, but at the same time, it's about perhaps, you know, yeah, looking at that context. And I feel very passionately that, you know, care for older people, some of the care we see, if we were seeing the same things in a children's home, there would be a far greater outcry. And I certainly think there is something cultural in society about how we're prioritising the needs of older people, and profiling that. And that's why I'm passionate about, and my team is passionate about the work that they do, for precisely that reason. But we're part of the jigsaw here, and obviously there are issues for commissioners of services at a time of austerity, when I think, I'm not a politician, and I'm not here to say anything political, but no. But I think that, yes, but I think that, that there is an aspect of certainly, funding within this, but also priority in the national consciousness and just, out there in society.
And just one last one, please. Your precursor organisation, going back 20 years, was sort of moving more towards naming and shaming. You seem to be now much more collaborative in the way that you work, and I wondered, in that vein, if you have anything to learn from Ofsted, in particular with developing leadership within failing organisations.
Are you referring directly to the Independent Age report? There are some things which are...
Yes, but the overall principle that new blood is often needed.
So you're talking about leadership in the care homes themselves. I think that, because one of the things in the Independent Age report, it talked about a good model of good practice in Leicestershire. And certainly, we do have similar models operating in Kirklees, where we have, a care home support team from the, CCG and local authority. We have our meetings collectively where we share intelligence, and the provider networks that I was describing, where we do go and we have a presence. I think it's really important, and that's something that I, insist on in my team as well, that for those inspectors who feel comfortable to be able to go to a forum and present, then they do assist me or go along and actually attend those forums to actually give our perspective on on how to get to good and outstanding, because that's something that we do want to pile in a lot of support from our perspective into. We aren't, as David Bean famously said, we aren't an improvement agency, but we are an agent for improvement. So that actually, whilst these kind of are bits around the outside of our main lever, which is using the regulations, I think it is important that we illustrate very clearly what we expect to see in good and outstanding services. And obviously, one of the tenets of that is good leadership. We don't have a role to teach good leadership, but we have a role to explain what that looks like in the context of our our inspection methodology. And obviously, we will support our colleagues as well within those discussions where they are. So partly, the outstanding, and certainly when it comes to the outstanding workshop, which I think is probably towards the end of the year or beginning of next for well-led, that's going to be critical in terms of us demonstrating exactly what we expect to see in terms of, good, well-led services, and that will be a part of the bigger picture of what will be shared at that event to do with, the local authority and other partners, actually sharing what good practice looks like too.
I think, Councillor, I would just add that increasingly, whilst the role of the CQC is in terms of looking at individual providers, they also play quite a critical system-wide role. So you'll be aware through some of the work that's been done around the CQC system reviews. So much of their role, I think it's increasingly, as Helen described, an agent for improvement, and that's system-wide improvement. So cross-cutting organisational boundaries, looking at people across the spectrum of care, I think that's becoming increasingly important. I would also echo the point about collaboration. So I think certainly the system, as have we, as a local authority in partnership with our health services, moved into that space of working with our care homes. And the reference earlier in the presentation to the CHESP, which is an acronym for the Care Home Early Support and Prevention Group, which Tony, my colleague, chairs. Again, that brings it into very much a collaborative space, of sharing information at the earliest opportunity, so we can then sort of land in those homes and apply that preventative approach.
Hello, I'd like to ask a question. My question is for you, Helen. I'm Alison Monroe, and it's kind of following on from my colleague Peter's questions. It's in the context of services. So where a nursing home has received a rating of inadequate, how are you addressing actual care itself? Because that really comes from within a person. So I just wonder if you could explain that, and what are the issues that you come across around care? And then finally, the third question is, could you explain, if I've understood this, how a focus on person-centred care might address those problems? Thank you.
Three-part question. So the first was about how we're actually addressing poor person-centred care, I guess, inadequate care settings. So I think, in light of what you were saying about collaboration, certainly, we are only part of the jigsaw within the puzzle here, albeit we have a very significant and important role to play. So in inadequate scenario where we go in and we find inadequate care, so we have a range of options available to us in terms of enforcement to lever improvement, and they can be criminal, civil, and we can issue fines as well. And we will always meet with the provider and have very close conversation after that inspection, so that the provider knows exactly what needs to happen, what needs to change. But I think that more commonly what we're seeing is that actually we see staff trying to do a good job, and actually the inspectors struggle sometimes with the domain of caring with inadequate service, because sometimes what they do observe lots of good caring interactions. However, that is then mitigated and confused by and hindered by poor leadership and poor governance. And a lot of the problems, and I haven't talked thematically about, because they're very repetitive actually, they're similar to last year, the same issues come back time and time again. But actually where you get poor leadership, you might have chaotic management, so you might have close succession of people leaving as manager, not being registered, because obviously having a registered manager registered with us, that's a commitment, and that's a strengthened sort of service in terms of our approach to regulation, because it means that we can target them with enforcement action should we need to lever improvement in that way. And it's about stability for any team. If they're governed by a leader who's been there consistently, then that does strengthen a team. But not only that, it's about having, so sometimes we find with inadequate services that actually you might have a strong leader who is being undermined by the provider, and the provider is failing to provide the correct support. So in inadequate services, all of those things may be in play, and they all affect then staff consistency of approach, which ultimately affects safety, because actually where you have poor governance, it follows that you have poor levels of safety. It's very unusual to have a service where you have very poor governance, so inadequate in well led, and that doesn't affect safety, because safety is your bottom line. And Regulation 12 is one of the most, Regulation 12 and Regulation 17 are the most, if you look at our reports, they are the most problematic areas. Regulation 9 is about person-centred care, and actually we're using that as a breach less and less. And also aligned to that, we're finding that actually Regulation 10 in terms of dignity and respect, which kind of coalesces with caring domain and what we look for in terms of compassionate, kind care, that those breaches are less than they were, which is all very positive. But the sticking point, because actually you can have individuals delivering person-centred care, but actually being able to acknowledge what that looks like in a wider culture, and a culture where that runs right throughout everything, so the person is at the heart of everything that is done, that is less common. So in terms of so there's a cultural issue. So I think that generally most staff know what good care is and how to respond to individuals, but the weaker the governance, then the more you're depending on the goodwill of the individual staff rather than actually being led effectively.
Yes, thank you very much.
I've got 3 questions for Helen, and then I've got questions for yourself, Helen, first of all. In terms of going out for inspection and then re-inspection, how much interaction or influence do the services have to influence how you rate that in a particular service, if any? Or is it more of a clinical approach, statistics and things like that? Thank you.
So when we go out and you're talking about general inspection, you're talking about inadequate services. Sorry. So our inspection method is that we need to be able to demonstrate user voice throughout our inspection reports. So in each of the domains, we need inspectors to be able to demonstrate that they have spoken to people about their experiences. We use experts by experience, so we have a proportion of people commonly from Remploy who we commission to provide the experts by experience to assist us on inspections. And a high proportion of inspections will have an expert assisting. If they don't have an expert assisting, and it's usually to do with the size of the service, because we don't want to overwhelm, a smaller service, say a learning disability service that's a small bedded home with lots of inspectors, but also it's not within the bounds of the role of the inspector to be able to ask questions of people who use services. But on inspection, that's just one element. We collate user voice from feedback that we get, and actually one of the things that had grown exponentially over, certainly since our new approach took hold, is that we've become much, and I reported on this I think last time, that we've become much more known in the public consciousness of our existence. So people do provide us with intelligence. So that might be friends, it might be other professionals who are sharing information with us, and people themselves actually, telling us about their care, and they can do it anonymously, or they can do it and actually speak to an inspector by contacting our contact centre. And all that information is what we use for insight in terms of being able to know, is there a hotspot here that we need to go out sooner? So that's when we're planning and actually going out on inspection. Where we follow up on inspection, so for poor services, so inadequate services, we will re-inspect within 6 months. And I want to draw attention to the independent age report, which sort of says about 6 months being a long time to leave. Well, we don't leave it, we will continue to monitor. And usually what happens is, because we win the trust of whistleblowers who share information with us, they will continue to share information with us in the background about what is happening within the service. So we continue to have a dialogue with them. And importantly as well, we continue to have a dialogue through the CHEST meetings, so the early warning meetings. But also we will have enhanced meetings, so sometimes there is safeguarding that is in play, whereby we contribute to those discussions, because usually in an adequate service it does, there is ongoing safeguarding that may be a feature as well. And so user voices are represented, by professionals in that forum as well. So there are a range of means that we have. And I think increasingly people are sharing information with us.
Thank you for that. Just moving on to my next question. In terms of those places that have been inspected have come up as required improvements, you mentioned you set up a meeting and you attend the meeting and you left it at that. So I'm just wanting you to kind of just elaborate on that a little bit further, because what is it that you do? Help, do a plan, or, and obviously for the viewers outside, is it more than a meeting, or what kind of steps that you have and what interactions you have with them? Thank you.
So it is really important, I think, to have that meeting. As I've said, we're not mandated to do so after one repeat of requires improvement. We're to consider it, but not mandated to actually go ahead and have the meeting. But I feel it's always beneficial because I think that the providers do, if I haven't already met them, then they get a feel for what our expectations are. And I think there's something about speaking in very clear, plain language and having a frank and open discussion. And sometimes it's about taking a proportionate view as well, because there may be specific reasons that actually you can see that improvement can be levered and the conversation happens in a different way. However, if we need to be able to, if it's part of enforcement, which it might be, then the provider needs to be able to submit an action plan to us, and we talk through the issues we found at inspection, and we ask them to reply about how they've actually started to address those issues. And we will meet with the manager, if there is one present, albeit registered or not. They come along to the meeting, and the provider as well. And one of the things I'm very keen to ascertain at that meeting is the level of communication between the manager and the provider, and the level of support for the manager, who actually has a very difficult and challenging job. So we look at those factors, and my inspector is there as well with their findings from the location inspection. And so what we do is I give an overarching about how we want to lever improvement and how we expect to see the service improve. The inspector goes through the issues they found. We ask the provider to provide a response about what they're doing in conjunction with the manager, and then we talk about next steps in terms of the things that we expect to see, and the fact that we will continue to monitor as well for intelligence. So at any time we can bring an inspection forward if we're concerned.
Can we just clarify as well on that point? Do you want the CCG and the council come in on this? Because do you work with as part of this meeting, and what support you put in? Yes.
So just very briefly, I wanted to jump in lots and lots, because I think we've mentioned the CHEST meeting, but actually we've got an awful lot more in place across Kirklees as part of our integrated care home quality improvement offer. I'm not sure you would want me to go through all of that today, because it might be a long day, but if that is something that you do want to hear about in future, then by all means we're more than happy to do that. In relation to a care home rated as inadequate or requires improvement, we have a multi-agency approach in that there is a proactive and a reactive intervention in place currently. CHESP is one very small part, which is about sharing quality intelligence. We have a number of quality improvement initiatives and teams within our commissioning and provider services that are dedicated to improving the lives of individuals who live in care homes. And I won't go into it in too much detail, but for me the question is very much, what is the system doing in relation to a care home being rated as inadequate or requires improvement, and what is the system doing to ensure that people remain at the good? And I'm hoping in the not too distant future a care home with an outstanding report from CQC. So yeah, there is an awful lot. There's a lot more than said. And if I could just reference back the question you asked about themes. One of the things we do with the Care Home Early Support and Prevention Group is do a thematic review of the kind of concerns that come through to us. And the biggest issue every single meeting is staffing. whether that's nursing or non-nurses within those environments, it's staffing. And then what we see is everything you would expect to fall out of that, which is poor care planning, moving and handling needs, nutrition, hydration needs, personal cares, not actually meeting the standard you would expect if a service was staffed appropriately, or if the staff were being used appropriately is another issue.
Just the last question. You mentioned that workshops for outstanding places that obviously have outstanding. What about the ones that obviously still require improvement? Have you got a system in place where they can come and obviously meet others and learn from them? Best practices, obviously, from learning from people who've actually been there and done that kind of thing. Thank you.
So the sessions are open to all providers. In relation to very specific activity for requires improvement and inadequate, we do have individual processes in place to meet with those providers and look at work on that basis. But we are also developing that network for inadequate and requires improvement providers. Indeed, one of the conversations we're having at the Independent Sector Provider Forum that we've already had, we've done a huge amount of engagement and collaboration in terms of putting together the quality improvement programme, but it's to continue with that, what would work, because we might know what we think we know, but we're not there all day, every day, so there's no point us trying to implement something that isn't going to work for the provider. So it's work in progress, in essence.
Right. Well, first of all, Helen, I want to say how grateful I am for the way you delivered your report, because it has confirmed to me that I've sat here for several months now receiving things that I can only describe as gobbledygook. And I'm saying this because I hope other people are listening. You know, this was clear. You obviously care so much about what you do. You've got lots of ideas, and if you had more money, this is what you'd do, and that's what you'd do. And I found it extremely moving, actually. But what is... Just explain to me, on the page that says context of services, we've got nursing homes, residential care, home care. What's community care?
Community care is extra care, so it's care home, so it's where you have accommodation providing personal care. So actually we wouldn't look at the accommodation, but we would look at the... So it's like semi-independent? Yes, yeah. where people can access personal care as well. Lacala, have they got any extra care? No, I don't think, because they don't have... No, they wouldn't, no.
Right, moving on to David. I'm interested in what an inspection consists of. And second question, why is Kirklees such a small proportion of the inspections that take place in West Yorkshire and Harrogate?
Would you like to know about, are we talking about a comprehensive inspection, or are we talking about the focused inspections that we're looking to move towards?
Well, you've presented a report about inspections. I think it's for you to tell us what you're talking about.
Yeah, that's fine. Okay, so if I perhaps talk you through some of the things that haven't changed, and then some of the things that have changed, and hopefully that will help to answer your questions in terms of inspections. Okay, so some things that haven't changed in terms of our approach to GP practice inspections. We continue to inspect in response to risk, as we have done always. So if information comes into the Commission that highlights concerns or suggests there's a need for us to go and inspect, we will go and inspect. We continue to inspect GP services that are rated as inadequate within 6 months of the publication of that report. And for services that are rated as requires improvement overall, we'll inspect those again within 12 months. And those will be comprehensive inspections, which look at the 5 key questions of our services: safe, effective, caring, responsive and well-led. And they also focus on the 6 population groups that we identify for GP practices. So inspections of those services will continue to remain as comprehensive inspections looking at the full scope and provision of services provided. For services that register with us as new legal entities, we inspect those within 12 months of registration with us. They too will be comprehensive inspections, looking at each of the 5 key questions. And for services that are rated as good or outstanding, they are now inspected at least once every 5 years. That's a commitment that's been in place since 2017. Okay, so in terms of what's changing and how our inspection methodology is evolving, so from the start of this month, we've introduced a process called the Annual Regulatory Review. So that is a process that all of the good and outstanding rated services will go through each year. And it involves us analysing all of the information that we hold about the service. So that includes information such as the previous inspection report and information that comes in from other sources, so whether it's from commissioners, whether it's from the likes of NHS England, from people who use the service, and from all of the nationally available data sets that are available for primary care services. So we analyse all that information, and we'll also hold what's called a provider information collection telephone call with the service. During that call, we have a structured set of questions that we go through with each service, and they're published on our website. And we use those questions to help inform the annual regulatory review. They are as important as the rest of the information that we hold about services. And if there is an indication, once the full annual regulatory review process has been concluded, if there's an indication that there's been a substantial change to the quality of services that are being provided, that can then trigger an inspection from the annual regulatory review. Now, that inspection will be informed by the information that has been analysed as part of that review. And that inspection can be comprehensive for that stage if we have concerns over each of the 5 key questions. Or it can be focused on the areas where there's been an indication where there's been a change in the quality of care. So that's either an improvement or a decline in the quality of the care. Does that help to answer your first part, or is that too detailed for you?
Yeah, my question was, what does an inspection consist of? Now, what I've picked up from you so far is that you look at data that you've got on a place, and then you make a phone call. Is that what an inspection consists of, or is there more?
Sorry, that's not an inspection, that's the annual regulatory review. That's separate to an inspection. The inspection itself involves us crossing the threshold. We speak to the staff, we speak to the patients, we assess the quality of care as it is in the service on that day. Generally, an inspection will be one day. If the inspector feels there's a need to go back on a second or even a third day because there's information that we need to gather, there are areas that we need to gather more information on, then they have that scope to extend that. But a typical inspection, yes, would be over the course of one day.
And do you talk to all partners in the practice on that day?
What we do is, obviously there's a limit to the amount of work that we can get through on a day. An inspection team will generally consist of a lead inspector. We'll take a specialist advisor with us, which will tend to be a practicing GP. We can also take other special advisors if there's an identified need or if there are areas that we need particular people to look at. And we also sometimes take a second CQC inspector as part of the team as well. So a team will typically be 2 or 3 people. What we'll do is we'll ask the provider to make available as many staff as they can for us within the scope of, obviously they're still operating on the day we're there, so we ask them to make available as many people as we can to speak with them, put together a structured timetable for the day. So we may not always speak to every partner, but we make efforts to speak to as many as we possibly can.
And do you take with you any information that you've had previous to the inspection? So if people, because people can contact you, can't they, and give you information, and that's your intelligence-led part of your process. So presumably you take all that intelligence that you've gathered about anything, a dental practice, a primary care practice, a care home, and then question around that when you're doing an inspection.
Yeah, certainly the information that we hold and that is shared with us pre-inspection does help to inform our key lines of inquiry on the day, yes.
I will just say that my brother's a retired GP, and in the wake of the Harold Shipman affair, when thousands and thousands of pounds were spent inspecting GPs, after he'd had the visit, he and his partners sat around and discussed whether, had they been Harold Shipman, they would have been detected, and they all agreed that they would not. Okay. Right, so going on then, in your presentation on page 30, you talked about introducing ratings for independent consulting doctors. Let's just call a spade, shall we?
In terms of...
What is an independent consulting doctor?
Okay, this is a term that we use internally to classify these services. It tends to be services that patients will pay a fee to use and access. So private healthcare is a simple way to put it for you.
You inspect both primary care practices who take national health patients and practices that take private patients as well. You inspect everybody, don't you?
We do inspect everybody. Yeah. We have inspected the independent consulting doctors or the private healthcare before, just we haven't had the powers to rate those services until the 1st of April this year.
Yeah, as you may have detected, my objection is to your terminology, not to the fact that you're doing it. It's the fact that you don't call it private medicine when that's what it is.
Yeah, David, while we're on the sort of spectrum that an inspection takes, I just wondered how much you'd picked up, and this is Kirklees specific, because you've probably gathered from my colleague, there is a move to run down acute hospital provision in Kirklees overall in Dewsbury and in Huddersfield, meaning that, of course, many more people will need to be looked after by a GP. And I just wondered, within the spectrum of your activity, whether you'd made any analysis of what our CCG calls care closer to home, which is delivered fundamentally by Locala, but needs GP leadership. I just wondered if you'd managed to pick up any evidence as to how that was working.
Certainly, the areas such as partnership working and working with other service providers is something that we do routinely look at as part of the GP inspection activity, and care closer to home is a term that's familiar to me in terms of what we report on in our inspection reports. In terms of the impact of it on the care that's being provided, I think that the standard of care across Kirklees is generally good, and particularly when it comes to things like the two key questions of effective and the caring key question as well. They do come out as good or better in the vast majority of services across Kirklees. So the evidence at the moment is that there's certainly no detriment to the care that's being provided through GP practice services at the moment, but obviously we'll be keeping a close eye on that and continuing to assess that as time goes on.
Yeah, I mean, I think there are sort of specific concerns that arise if you've not got an acute hospital on your doorstep, and that's how well are you managing chronic disease? What are you doing to prevent hospital admission? How quickly are you helping people to get out of hospital if they've had to go in? And those sorts of parameters. And we've never managed to get any sort of evidence that says, we're actually looking after more people at home. There's a lot of sloganising, and that's very good, because we'd all prefer to be looked after at home, even though we love the infirmary. But I've just wondered, and of course, under your umbrella of ambition, presumably you'll be keeping an eye on this through your analysis of primary care networks.
Yeah, and certainly there's certainly a plan nationally to look at more to complete some more local system reviews. So obviously there was a tranche of 20 that were completed nationally during the course of the last calendar year. There is an intention for us to do some more of those. Not that all looks at things like, as has been referred to earlier on, looking about care along the full pathway. So the interaction between primary care and secondary care, and obviously then linking back to care at home as well. So it's definitely an area of work that we're looking to expand our role in, and hopefully the commissioning of some additional local system reviews will help us to do that.
So just picking up on your themes then, because when a hospital has an inspection, they also have a action plan, just like the care homes, etc. And the GP practices, they have an action plan as well, and CQC advise on the action plan. So when you're picking up themes in this new approach that you're doing, will you be picking up the themes of that are relevant to the areas? So, for instance, like the movement from hospital services to more closer services to home, etc. And or will you just be going in and inspecting a facility? Because at the moment you go in and you inspect a hospital, you go in and you inspect a GP practice, you go in and inspect a dentist, and you go in and inspect a care home. So with the themes, are you going to inspect several things across that theme rather than just one facility at a time?
There will definitely be an increase in cross-sector and cross-directorate working within CQC. So an example of that is obviously, I can give that reflects locally, it will be the re-inspection of low collar when that comes around. They're already in discussions across the West Yorkshire footprint in terms of how each of the directorates can support that activity. So obviously they have the community services they deliver, they have some GP practices that they have contracts for, they have some social care provision as well that they're also involved in. So there will be more examples of that and that cross-sector collaboration in terms of assessing these larger providers at scale and what their impact on the system is moving forward, so that is something you should be able to notice.
It's just that if you're taking a particular theme, it may be that it's cross-facility. That's where I was coming from. Did the CG want to come in at all? Tony and Saf, did you want to come in at all on this?
Yeah. So in particular relation to care homes, one of the pieces of work that we do across the system is look at how we support people to get back out of hospital. But one of the things that for me we always need to think about is how do we prevent somebody getting in hospital in the first place. So we're looking at some deep dive into the causes for admissions into acute hospitals from care homes so that we can provide some proactive support into those services, because generally the reasons that people are admitted to hospital from a care home is due to urinary tract infection, chest infection or generalised sepsis. And we know that basic fundamentals of care are very good at preventing some of those things. So we did see last summer when it was very, very hot, lots of fluids being pushed because it was very hot, so we had a significant reduction in the numbers of urinary tract infections because it was hot and those fluids are being pushed, which was an interesting kind of byproduct really, and a very good one. So it shows us getting the fundamental basics right impacts therefore on the hospital experience or not. So therefore the tie-in for me from an inspection perspective is, are we working together to make sure that the care homes have got the right systems and processes to make sure that the fundamental basics of care are delivered, and the ability to understand symptoms and what that means and what you therefore need to do about that, whether that's a call through to primary care, district nurse, or whether it sits within a care closer to home. So we would look at that there in that care home sector, which then we should see the benefits of within the acute hospital sector, and we'll see within primary care as well. So that's how I see the crossover there really, making sure that each area has got its start and finish right, the beginning and the end of that episode of care.
Just picking up your question, Councillor Smidge, about themes. I referenced earlier the system reviews that CQC are doing, so the panel will be interested in the Beyond Barriers report that CQC published, and that looked at, I think initially 20 systems across the country, understanding the interface or the journey that older people took, older people take across the entire care system. So whilst Kirklees isn't and wasn't one of the areas that was targeted as part of that review, we are jointly with our partners undertaking a sort of softer review internally so that we've got a good understanding of what our strengths are place-based, as well as areas for improvement. I'd also suggest that the panel will want to look at the CQC data profile. So again, that gives you a place-based view of those thematic things that you talked about earlier in terms of what's our profile of residential care, nursing care, hospital, bed-based services, etc., etc. And again, that presents that kind of more place, Kirklees-based picture of the state of care.
I can provide that report to you if you'd like. I can forward it to you, Richard.
Thank you, Liz. It's going back to your inspections. Given that the services, particularly at Dewsbury Hospital, are very limited and GPs are overworked, can you tell me that what sort of in terms of recommendations you make to particularly like care close to home? So who monitors that? You know, do you wait for the next inspection, or do you go in between that you've made those set of recommendations to see whether or not they're being actually picked up on, or systems are being set up, or structures that are required, or is it that you wait until the next inspection?
Can I just check that you're talking about recommendations made to individual GP practices? Yeah. Okay, so if there are areas for improvement that we identify for GP services, if there are breaches of regulation, there is a requirement that they need to send us an action plan in terms of how they're going to move those matters forwards. And then during, obviously, the service initially suggests to us the date by which those actions will be completed. We will assess that and see whether we feel that is appropriate. If we feel it's appropriate, then that's fine, we'll accept that action plan, and we'll keep in contact with the service in terms of them updating us on the progress they're making. If we feel that they are suggesting a date that is perhaps for them, it's taking a little bit longer than we would like to see for the improvements to be made, then we'll return the action plan back to them and ask them to reconsider that. And then again, we'll get to the point where we're happy to accept an action plan, and we'll stay in touch with that service until we go back to re-inspect the improvements that have been made.
So, say for example, a practice is inadequate, and you've tried and tested whatever methods you need to, and there's been no improvement. What's the next step?
Okay, so if a service is inadequate, it gets placed into special measures, first of all, which will, for GP service, which will then open the door to a support package from the likes of commissioners. Also, the Royal College of GPs also have a support package for services that are placed into special measures that the service can access. If we go back and re-inspect and there are still areas which are potentially going to be rated as inadequate, then we'll just follow our enforcement processes again. We'll take the information that we have at that point in time in terms of the latest information, assess whether there's a need for us to take any further enforcement action, or whether indeed there's a need to extend the period of special measures. So we'll continue to work with the service in terms of helping and encouraging them to improve. And obviously the decision taken will be based on the evidence that's gathered at the most recent inspection as to what happens next from that point.
I'm aware mental health isn't here, and I had loads of questions for mental health, and I know you said obviously you'll try your best. I would like to just mention, before I go on to Jonathan and ask you a question, is that I find it quite upsetting, and the fact that it's really ridiculous, the fact that nobody is here to substitute somebody so we can talk about the report itself, or the lack of information that's been in the report. We get, page 32 of our report states that there is concerns about what's happened in terms of the changes. We've increased the number of places that we've rated as good to 70%. In comparison to what there seems to be lack of evidence of what was last year, without me having to dig through anything else. Anybody else that's either watching this on webcast or even having a look at our documentation would not. To your reports for your bit, and even the dental stuff, we've got places and things that we can compare, have a look, actually see what's the difference. The report for the bit that's come from mental health is absolutely shocking, and it's disgusting, really. But if you expect all of us to be here and listen to this, I find it quite upsetting and disgusting. I'm really sorry, and it's not a personal dig at you or anything like that. But the fact is, I've read through this, and I thought I'll have questions, and I'll ask them as to why I've only got 2 pieces of paper telling me, obviously they have concerns. The waiting times have increased. Mental health is such a big issue, and not having even a substitute here I'm sorry, it's not acceptable at all.
In response, in support of my colleagues, I have to say that I've been on jury service the last 2 weeks, and that has hampered some of the communication to ensure exactly what was happening. So I take responsibility for some of that today. But certainly, if you have specific questions, we will, take that back to our colleagues. The other thing that I would like to say is that I haven't mentioned in my presentation, but in terms of mental health Directorate are supporting adult social care presently in rolling out, developing some training, because we all have areas of interest that are designated as part of our role within the Commission. And my area of interest is mental health, because that's where I come from. That's part of my background. I'm a registered mental health nurse, and one of the things I'm very keen to see is improvements in mental health facilities within adult social care, and Mental Health Directorate are supporting specifically some training for our adult social care inspectors around that. So that's just the development I'd like to highlight from our colleagues who are supporting that.
Like I said, it wasn't a personal thing at you, it's just the lack of information that was provided, therefore we couldn't go forward. But thank you for that.
Can I give you a little bit of commentary on something you've just asked? Because there are some brief notes that we have at the bottom of our...
on your pages,
yeah.
It's about IACT and obviously the waiting lists and stuff like that.
I can give you a bit of context as to the ratings in previous years, just to try and give a bit of a picture of the improvement trajectory. So it says as at 31st of July 2017, the ratings for 54 mental health trusts, at that time there were 4% outstanding, 59% were good, and 35% were requires improvement, and 2% inadequate. Yeah, absolutely, yeah.
Can we just, around the mental health then, does the CCG want to come in at all on this? Because we have, in this, there is actually some contradictory information. I think that's where we're coming from as well. Because one of the things she said is the development of an older people's crisis team in Kirklees, which, excellent, has reduced the number of admissions to inpatient wards significantly. Well, it may have reduced admissions on older people, but we've heard from the Mental Health Trust that there's a spike in men between certain ages are presenting as acute mental health, and therefore the number of admissions has actually gone up in relation to the services. And also the community mental health services waiting lists. How are the CCG and the SWIFT being supported by CQC in this to actually ensure that these core services that were rated as requires improvement in this area are improving? So does the CG want to come in on any of this?
Well, I can to a limited extent, but it's not actually my area of responsibility in terms of mental health commissioning. However, I will just contribute some experience in terms of older people's admissions, in that I do know that SWIFT are actually struggling significantly in relation to the numbers of referrals to their inpatient unit, which has resulted in us needing to match the approaches that we have with our acute hospital colleagues in terms of discharge facilitation. So I don't have any facts and figures or anything to formally corroborate that, but I do know that it feels that there hasn't been a reduction in the system, if that is acceptable.
That actually goes with what we do, hence the reason the frustration is there's not somebody here to ask, being able to ask these questions. But yeah, thank you. I'll go on to the dental, and I promise to be nicer. It's a question I actually asked you last year about the 10% of mapping of the dental services. I'm quite sure you can watch it last year if it's still online. About how you picked those 10%. And you were going to provide us with a map this time around, or possibly as to where you've actually been. So just give us an idea of where in cases that you've been.
Okay, so the 10% are based on if we get risk which comes, and that always trumps any inspection which we have. So we schedule our inspections for 6 months in advance. So we choose these initially randomly. If we get areas of concern from staff members, from members of the public, from NHS England, from the General Dental Council, we substitute any inspections so the risk one always trumps everything. So whether it's an announced inspection, a 2-week announced, so we get the risk in, we assess what the level of the risk is. If it's urgent, we do an unannounced inspection. If it's not so high risk but still warrants looking at, we can do a 2-week announced, or again we've got a process where we can do a short announced, so it could be 2 days, it could be 1 day, and we discuss that with our managers initially to decide when we go in with that one.
It's just the NHS registered one, the dental services that you register, or is it?
All services, so private and NHS, yes.
Final question, sorry. In terms of rating, you do not rate it at all. Is there any scope of possibly trying to rate it? Because there is either you can be, you know, what is the bar kind of thing to be able to say you're okay and you're not okay.
We talk about it a great deal about rating services. The problem is, because we've already started off the inspection programme, we've done 30% of services which are compliant or not compliant, whereas if we were going to start rating, we've got that 30% who haven't had the opportunity to be outstanding. So we would put them at a bit back if they could say, actually what we're doing is outstanding, and they can have a banner out front of their practice saying we are outstanding, whereas one that's doing something similar, if we did start rating, then they would be able to have that mantle of being outstanding. But it is something we do talk about, but I said nothing as of yet.
Sorry, David, I spent so long getting out of you what an inspection consists of that I didn't wring out of you what the second question was, which was, why is Kirklees such a small proportion of overall inspections in West Yorkshire and Harrogate?
Okay, so my team cover 9 CCG areas in total. I have 7 inspectors. So it is just a proportion of the work that we complete during the course of the year. It's no greater or less than inspections in any other area. It's proportionate to the size of the area.
So,
would you like me to try and illustrate that with the numbers?
Can you just expand that a little bit, because Kirklees is quite big.
Okay.
I think, what are you saying that in a year, so next year you might go up or down in an area if you're intelligence led, and you'd be going into areas where there were more problems than other areas, or how have you decided on the proportion of
over the last 12 months?
Inspections over the last 12 months? Yeah.
Okay, so in part it is driven by changes in registrations. So obviously, if there's been new registrations, we inspect those within 12 months, so they will always fall into the remit. If services have been rated good or outstanding, unless there has been identified risk and they've not reached the point of 5 years since the last inspection, we haven't revisited those. So because the services mostly within Kirklees are good or outstanding for GP practices, there hasn't been that trigger for us to go in and inspect unless we've heard information of concern to be able to back that up. So there's a combination of that plus the 5-year programme plus new registrations plus changes of legal entity. It's a weird and wonderful mix, but over the course of if you looked at a 5-year time frame, we would go back to all of the good and outstanding services and re-inspect those. So it may just be that Kirklees has had a lot of services which were inspected in, say, 2016-17, whereas other areas of West Yorkshire were front-loaded at the start of the programme in 2014-15, so it's a combination of factors.
Yeah, I just wondered, while we're on it, David, how much single-handedness is a feature of limited performance?
I think this is a question you asked me last year as well, actually. I think you can have a well-led single-handed service in the same way you can have a well-led service that is a partnership or even a super partnership. It's very much down to local leadership. You do see very good and not so good services of all types. I think obviously when it's stating the obvious to a degree that when you're reliant on a single hand or a single person who's carrying the governance can, if you want to talk about it like that. There is more of a focus and more of a need for that individual person to be committed. But that's not to say that we haven't seen evidence of that happening and of good practice.
Thank you. Right then, thank you ever so much for coming today. That's the end of that formal part of our meeting now. Can I just thank the panel for their work this year, because this is the final, unless something happens in the meantime and we need to meet urgently. This is the final meeting of this municipal year of the Scrutiny panel, so thank you ever so much everybody for your participation.
Well, Liz, I'd just like to say thank you very much, because I know how hard you work and you're just brilliant at it. Thank you.
Thank you very much. Thank you. Now you've put me off now. I was going to say.
What I meant to do.
Richard will be in touch for dates for next year as soon. We've probably put indicative dates down for next year, ready for the annual calendar of dates for meetings. Okay, but Richard will be in touch about that. All right, so thank you very much, everybody, and that ends the formal part of today's meeting. Thank you.